Guys, thank you all for joining us. I really appreciate it. Andrew, let me start with you, if I might. I'm not going by order of importance, just by who's on my screen as I look down and see. But talk about the accreditation, if you would, what it involved, why this was a years-long program, and what it means for the state to finally receive it.
Alphabetical helps sometimes, I guess.
Right.
So I'm a neurosurgeon. I treat mostly blood vessel problems, and I do treatments of blood vessel kind of things, both inside the blood vessels, what we call endovascular therapy, and when surgery is needed.
Mm-hmm.
And so I'm the surgical director of the stroke program, and Michelle is the medical director of the stroke program. And this really is a collaborative effort where a number of different disciplines need to work together to treat this complex problem of stroke. Why this is exciting for the state is because it recognizes the high level of care that we can provide to patients with the most complex and the most debilitating kinds of strokes. It recognizes our ability to work very quickly to get the right treatments to patients, whether that's giving patients medication or whether that's very quickly getting them into our angiography suite to be able to remove clots from the brain. Mm-hmm. And we know based on a lot of studies that have come out recently that stroke treatment has really changed over the last few years. We now can really improve the chances that somebody will have a good outcome after stroke. And so that's where this effort is incredibly important for New Mexico, because we have to be fast about it. And so trying to streamline all those processes, trying to streamline the groups that are working together to take care of these patients, and then, of course, extending that outreach across the rest of the state, which I think we'll talk about a little bit more later. Mm-hmm. But in order to get patients all over the state to be able to have access to that high-level care is really what the core of the comprehensive stroke designation is for us.
Gotcha. Torsten Roed, as I read it, you've been on this trail literally for a long time in your career. And why is it important for everyday New Mexicans to have this stroke center? Obviously, Andrew touched on this a little bit, but when time is an issue when it comes to strokes, why this center? Why the importance?
Well, the big deal there is that we are the only, at this time, but the first comprehensive stroke center, which means, as Dr. Carlson already pointed out, we can do some of the things that no other center in the state can do. Mm-hmm. We can do, of course, the thrombectomies. He talked about the mechanical removing of clots, but then also any kind of follow-up problems. If the patient has bleeds in the head, the neurosurgery part of it. So the big issue there is that these patients that Dr. Carlson described, the really debilitating strokes, should, if at all possible, come to us directly. Mm-hmm. That's really the big difference. So they might even have to bypass a hospital that's a little closer, but doesn't have the capabilities. So that's something that the state has to understand, and that we're talking with EMS, and that these patients then come to us, and we can take care of them from the moment they arrive to all the way till they're discharged. So mm-hmm. that includes our neurosurgery ICU unit. So that's also unique in the state. So the nursing care, the level of nursing care they receive, the constant availability of 24/7 of doctors, of neurosurgeons, of neurologists, everybody's here basically around the clock. And that's something that's quite unique in the state.
Yeah. I'm going to guess you've seen sort of both sides of this, meaning how we've done it to this point and what you anticipate being able to do better under this designation. Am I following that correctly?
Yes, of course. I mean, with Dr. Carlson coming back, our level of care would jumped up years and years ago already, and mm-hmm. now we just got finally the title that shows that we have this level of capabilities that we've actually already had for a few years now. I did see it before. I see it in my own family. My grandma had strokes, and that was debilitating, right? Months and months and months of rehab to get speech back. And when you see some of these patients come in with these devastating diagnoses, and then sometimes walk out in a few days later after we treated them, that's just something that is very special that you don't see in many other disciplines.
That is interesting. I'm glad you got that in. That is actually fascinating. Dr. Torby, Michael Torby, you're a stroke specialist and chair of the Department of Neurology. Let's get into access to critical cerebral emergency support services, or ACCESS telemedicine program. Tell us about ACCESS and what it does.
So thank you, Gene. The UNM Access program is our teleneurology platform, or emergency teleneurology platform, and it's currently present in more than 20 hospitals in rural New Mexico. When you think of New Mexico and you think of how the hospitals are dispersed, and as you mentioned earlier, time is brain, it makes it very challenging to bring all these patients to the main hospitals in the big cities so they could receive the care. Certainly makes it challenging to bring them all to one comprehensive stroke center and be able to then triage and try to figure out the best treatment. And then if you realize that, well, maybe this is not a stroke, now these patients are 2 hours away from home, no transportation, and it becomes a big challenge and financial issue. So what ACCESS allows us to do is we're able to beam in literally to these emergency rooms and examine these patients live and assess their symptoms and look at their imaging and decide whether indeed they're having a stroke, and then what type of strokes are having. Are they having an ischemic stroke where you have a blood vessels that's occluded, or are you having a hemorrhagic stroke where you have a blood vessel that burst? Right. And then if not, then they could stay in their local hospitals and don't need to come all the way. So this really allows us to also provide the right treatment right at the bedside. So for those patients who are having an acute stroke, we are able to give them the clot-busting medication at the bedside in the facility within the same speed that we would give them if they came immediately to our hospital. So you're elevating that level of care to almost a stroke center level of care, but then they need the next follow-up, which is now potentially taking the clot out, or they may need to come to the ICU. So you're really bringing the right patient to the right place in the right time. I think this combination is what makes it very successful as we treat the acute stroke patient. And if it's a hemorrhage patient, then, we already know that this patient is coming. The angio suite may be ready for the aneurysm coiling, or the ICU is ready for this patient. So you're really expediting the care across the board. And the Access Center is currently covered for all stroke patients by, our stroke team. Neurosurgery is also, covering for the neurosurgical emergency. And this is the way we connect the state and avoid unnecessary expensive transport, as you know.
Dr. Carlson, you touched on this just a little bit ago, and Dr. Torby just did a second ago as well, the new technologies that are out there. I have to say, as a layperson, I'm rather blown away watching video of going through a vein in the leg, coming all the way up into your brain to be able to reach another thing inside that tube to yank a smaller clot out. It's astounding, actually. Talk about the leaps that have been made over the past years and how this is accomplished.
Yeah, it really is exciting. I agree. I've only been out of training for 8 years doing this, and even in that time, the field has just remarkably changed in terms of what we're able to do through very minimally invasive and very safe approaches. And I think that, as Dr. Torbay mentioned, it's important to remember that there are 2 general categories of stroke. We have bleeding types of stroke, hemorrhagic stroke, and we have ischemic stroke, which means a blood vessel gets blocked off. And our ability to treat both of those things has just skyrocketed. So our ability to treat blood vessel ruptures, where something like an aneurysm bursts and cause bleeding in the brain, most of those cases we're able to now treat up through the leg, or sometimes even up through the wrist through just a tiny needle puncture, and be able to put a device or little metal coils or loops into the burst point and seal everything up, which is obviously a much less invasive approach than when we have to do surgery to put metal clips to seal those. But for ischemic stroke, this is really where things have revolutionized the field, just because it's so much more common. It's the most common type of stroke. And when a blood vessel gets blocked off, like the carotid artery or one of the main blood vessels going out to the side of the brain from a clot that comes from the heart or comes from the neck somewhere, exactly as you said, we're able to thread tiny tubes all the way up using just x-rays from a puncture in the leg, and then either retrieve that clot with a little net, or sometimes even put a little suction up right up to the clot and suck it out of there. If needed, we can open up the blood vessel and keep it open with a stent. And that's a proven treatment where we know that, that if we do that treatment for people who have blocked off blood vessels and still have brain that we can save, that there's a very good chance that we'll be able to get somebody not just to survive, but actually to have a good outcome, which is really what's different here. We're not talking about just making somebody survive, but in a severely debilitated state. We can actually make more people be able to be interactive, be able to be communicative, and be able to take care of themselves compared to if we couldn't do that treatment. So that's what's really exciting about the technological advances.
That's amazing. That's really through the wrist. That's amazing. Torsten Rhodes, what's the window now, as Dr. Carlson describes it? My understanding as a layperson is about 4 to 4.5 hours. You don't want to push it, obviously up to 4.5 hours, but what's the window? Has it narrowed in a way that you can get folks into a better recovery position?
Well, actually, we're working on extending those windows, right? So for the clot busting medication, TPA or Alteplase, there's now a couple of them out there. Our standard number is 3 hours, but we can extend this to 4.5. That's the number you have. Now, for the technology that Dr. Carlson is describing, we're looking at a 24-hour window. That still can be very effective, and maybe even depending on the situation, looking at stretching that. There are other ways. The one stroke that always confounded us is a wake-up stroke, right? Person goes to back normal, wakes up 8 hours later and has a stroke, and now we don't know when the stroke happened, so we always have to assume the last normal when it was seen the last time. And but there's even talk about looking at that and extending those windows. So it's moving in the direction of more intervention at later stages. But I'll let the doctors talk about that even more.
Yeah. Torsten, let me stay with you on this one, though. We should get into, again, another reminder for folks about what to look for in a stroke if you're out in public with your friends and family. I've been in 2 situations, both of them were cookouts, believe it or not, over the years, where there was a stroke situation. One was quite obvious and quite severe, but the other one, we literally had to talk the person. I wasn't part of this, but the person had to be talked into going to the hospital because they were, I feel all right. I just was sort of lightheaded. Well, a week later, I find out it turned out they did have a small stroke.
Yes.
How often does that happen where people feel like they're just a little bit off, but they don't feel like they need to take that next step, and they don't realize that something very serious is going on here?
Well, you make a great point. Education about that is probably one of our most important steps. So the recognition of the stroke, and especially now in this new world we're living with COVID, and people are afraid of going out. People are afraid going to the hospital. We had for a while concerns that people with slight symptoms decided not to go to the hospital because they were afraid of. So we had public announcements about that. So the mnemonic is, of course, is be fast that we're using. B is for balance. When you're suddenly off balance and you can't stand up, that might be a stroke symptoms. Eye deviation, when your eyes can't really look where you want them to. And then the obvious ones that we know for a long time, the facial droop. That's often the one that family recognizes. Mom, suddenly the one side of the face just falling. Then we have the arm that you can't move part of your body, usually the side that's opposite from what's affected in the brain. Speech, that's a big one too. That's actually the one that I would think that you talked earlier about people being at home and being alone.
Yes.
When you can suddenly get your words out, that's a big indication, and you do need to call if you can. And then the last one for be fast is time, right? Time is brain, as Dr. Torbe said. So we are recommending even slight symptoms. If you have a speech problem suddenly on set, or you're definitely facial droop. But even if your balance is off, do come in, let us look at you, let us scan you, and then these guys here on my right will be able to tell you what's going on.
Interesting. I have an aunt, she's long past now. She was a victim of a stroke. No one had gotten to her for a number of hours, and regrettably, she lived out the last 7 years of her life just not in a great place. It was really just not a good situation. And this, I've always gotten the feeling this is way more common than people realize. Like this is like sort of like the silent thing. We talk about silent killers, all that kind of thing. The problem with stroke is, there's a diminished life that happens sometimes when you do recover. And how to get across the seriousness of that you may end up in a chair, you may end up not being able to feed yourself. I mean, I don't mean to be dramatic here, don't get me wrong, but there are serious implications for when a stroke is not caught that sometimes I feel like the public's not quite snapping to. Do you have a sense of that you can help me with on this one?
Yeah, no, Gene, I mean, this is really an important issue. And to kind of follow up on what Torsten mentioned, I mean, the big challenge, as you've noted in some of these cookout, is when the patient develops stroke symptoms, and then the symptoms resolve completely. And this is what we call a TIA, or transient ischemic attack. At that stage, they feel they're fine and they don't want to go to the hospital. And it's important for patients to realize that the risk of a recurrent stroke is exactly the same, whether they had a TIA or a full big stroke that ended up by them needing to go to the hospital emergently. So this is what I tell my patient is this was your warning sign. And in a sense, it's important for you to go to the hospital to make sure that any problem is being addressed and fixed. And going to your question, a lot of it is because sometimes even in an acute setting, stroke is not a painful disease. Like when you're having a heart attack, you have the severe chest pain that radiating to your arm. And the reason you go to a hospital is mostly to get rid of the pain, not as much because of, you think, oh, I'm having a heart attack. And it's unfortunate from a stroke perspective, but also to help them in the recovery, which is going to be as important as getting the stroke therapy. Because if you can get the best therapy, let's say at UNM, and now you're going to go to rehab, and then in the rehab facility, they're not working on your stroke as they need to. But also, if the patient isn't following the recommendation from their stroke rehab docs, all the work that we've done in the first 24, 48 hours for this amazing recovery, the patient could get step backs and not perform at 100%. So it's a continuum of care that we have to really work as a team across the board, and with the patient being the center of this whole sort of process, to work with them and educate them on what would be the best way to get the optimum recovery.
It's important. It's important for New Mexico with an aging population. It's kind of a big deal. So thanks, guys. I really appreciate your time today. Absolutely.
We appreciate it. Thank you.
Thank you for having us, Gene.
My pleasure.